This is the MRI scan of a patient with left-sided pansinusitis with possibility of allergic fungal sinusitis. This MRI shows multiple T2 hypointensities in between hyperintense lesion on the left side, which raises the possibility of allergic fungal sinusitis. The patient has presented with nasal polyps. This ongoing DICOM image and video shows the extent of polyps and sinusitis, with bilateral disease much more on the left side. As you can see, the frontal sinus is crossly expanded on the left side, with erosion of the lamina papyracea anteriorly, expansion of the ethmoids, and demonstration of hyperdensities in the maxillary sinus. The right side also has some polyps as well as maxillary sinusitis, though less in quantity and as compared to the left side. The sphenoid too is involved here on both sides. Now, the plan here is standard, that is an endoscopic sinus surgery, and you also see a clip in the brain, that is a coil. This patient has been previously coiled for an ruptured aneurysm inside the brain at the anterior communicating artery. So, being a high-risk patient, the plan is to do a bilateral sinus surgery, possibly extended, with emphasis on the adequate opening of the frontal sinus, which sometimes could be restricted because of a thick frontal beak in some patients. Multiple samples are sent to confirm any presence of papilloma or malignancy in these patients, and generous samples of the tissue are also sent for KOH as well as fungal cultures. The IgE levels are also elevated in this patient, approximately to the tune of 1400 to 1500, thus adding suspicion of allergic fungal sinusitis. As you can see, what we see heads up on the left side is extensive polyposis that has pushed the middle turbinate medially towards the septum, and in fact also the uncinate process, which eventually becomes everted, masquerading as a polyp or polypoidal lesion, which is basically an everted uncinate process. So these lesions, sometimes extensive polyposis, extensive allergic fungal sinusitis, which has been there for quite some time, many years, can sometimes lead to a reasonable amount of bleeding, and one must have mental provisions for the same. A large polyp that completely occludes the nasopharynx and the choana is also visible, which can be consequentially debrided using a straight shaver. Once the initial debulking of the polyps is done from the middle meatus, from the choana, thus creating landmarks and surgical orientation, the next most important thing is a generous opening of the maxillary sinus. Now, even if the maxillary sinus does not contain much tissue, it still has to be opened widely, because not only is that important to clear off all the retained secretions, mucin, or actual fungus from the maxillary sinus, but it also guides to the overall perspective of the sinus surgery in the absence of normal landmarks. The posterior wall, the superior wall of the maxillary sinus, which is the inferior orbital wall, or the transitional wall between them, you can see the fungal tissue and the muck inside the maxillary sinus here with a lot of polyps. Now, this transitional ridge of the maxillary sinus, which is basically transition from the inferior orbital wall to the posterior maxillary bridge or line, is the approximate line of entry into the posterior ethmoids, thus safeguarding the skull base by not going too superiorly. As we clear out the maxillary sinus from polyps using a curved microdebrider, it's also important to not denude the sinus or create bare bone. And now we have essentially cleared most of the ethmoids, as well as they opened the sphenoid on the left side through a standard ethmoidal surgery. The surgical field generally is fairly oozy in these patients, and as you can see, uh, all excessive bone chips retained inside the sphenoid sinus or in the ethmoids should be removed. Most, if not all, of the bony partitions in the ethmoid sinuses should also be removed in an attempt to make the ethmoid cavity more or less flush with the skull base and the orbit, because this reduces the possibility of recurrences severely. If one or more of the ethmoids are not cleared and bony septations are kept, then the chances of recurrences in the ethmoid is generally high. One must also be careful because the lamina papyracea was dehiscent as seen in the preoperative CT. So while using powered instruments and shavers, one must exercise restraint while working in the area which has been previously mapped as being dehiscent while with regards to the orbit. Now, at a certain time when the surgical field is probably too oozy, and a basic enterostomy and ethmoidectomy and sphenoidotomy has been conducted, and one has to proceed to a frontal sinus opening. One can even, for the time being, use a small pack to gain some time and some hemostasis while you work on the other side. The only one thing that we strongly recommend against is continuously operating in a poor surgical field or a very bloody surgical field, because then that essentially significantly increases the chances of potential complications, orbital and skull base. Here one must also be cautious while enlarging the sphenoid inferiorly as to not to transect the septal branch of the sphenoparietal artery. As you see, as more and more of the edematous sphenoid mucosa we clear, there is still some party wall and polyp inside the sphenoid, which we are clearing. And again, some caution is exercising in not using the microdebrider too laterally and superiorly in the sphenoid sinus in an attempt to avoid injuring the skull base and the optic nerve. Once we have packed the left side for the time being, we resume the surgery on the right side, which is basically again the uncinectomy using a standard backbiter to avoid entering inside the orbit, and then using straight or angled true cuts along with the straight microdebrider initially to create our ethmoidectomy cavity. As you can see, the amount of polyposis and inflammation on the right side is considerably less as compared to the left side, and thus the surgery on the right side seems to be more simple in the way of having less bleeding, less polyps, and one can identify landmarks anterior to posteriorly much more easily as compared to what it was for the left side in the presence of extreme inflammation. All attempts must be made to clear this ethmoid cavity flush to the lateral nasal wall and not leave a lot of lateral nasal wall there, because then cells are often left behind. Also, it's important to not go that laterally as to open the orbit. Even if one does not injure the optic nerve or any muscle, even the simple egress of the orbital fat into the ethmoidal cavity is good enough to jeopardize a clean surgery. Hence, all care must be taken, at least in the initial part of the surgery, to avoid transecting the orbit or causing a fat herniation. Plus, while working with a microdebrider, one must be very aware that the fat could be very easily sucked out within seconds, thus causing major uh, possibilities of complication as compared to using cold instruments. Here you can see, once we have transected the superior turbinate, that would make our entry into the sphenoid sinus. And now we are just clearing some excess tissue and polyps from the area of the frontal recess to be able to open that better. Blind pulling of tissue in the frontal recess is strongly recommended against, because that leads to scarring. As you see, a lot of thick mucin comes out of the right maxillary sinus. Now, once the that side has been taken care of, we put our attention again towards the left side, and as we see that we could still not see the frontal recess opening, it seems to be very crowded and restricted. So, a decision was made to drill the thick frontal beak to create a larger opening because the frontal sinus was grossly involved in the CT scan, and a reasonably large opening is definitely planned in this patient, which was not possible because of the thick beak and tight or very restricted frontal sinus recess. As you can see, a straight an angled microdivider blade is not able to go upwards, and we do not want to do any blind instrumentation here. So what we will do is we will uh, plan for some drilling of the frontal sinus, not maybe a full draft 2B, lesser than that, but to drill off the frontal beak so that we get a reasonably adequate access into the frontal sinus proper. While working with the microdivider in the frontal recess, one must also be careful about the anterior ethmoidal artery, which can be very easily injured in this part of the surgery. And one must identify that very, very early to avoid any orbital hematoma and possible vision loss. So as we see, once we are now using an angled endoscope, looking upwards, and you see the ethmoidectomy cavity is flush with the skull base. And now, with the fact that very little can be seen in the frontal sinus or recess, now we start creating more access by initially using the articulated bone punch to see if we can manage biting off some of the bone of the frontal beak and avoiding drilling. But as you can see, the frontal sinus or recess opening is just barely seen, not adequate even for a suction to go right now, completely inside, and which tells us that because we see a significant amount of disease here, a lot of polyp tissues, we would need some drilling and enlarging of this frontal sinus ostium. So what we do is we expose some of the uh, frontonasal bone or the frontal process of the maxilla, the using a coablator to basically just identify bare bone here, which would be then used for drilling. We do not want to, as of now, we do not want to do a full draft 2B. So we're not creating a flap over the septum and not transiting the middle turbinate. So the goal is just to drill the beak significantly for us to give us a clear and adequate entry inside the frontal sinus proper. So we're using a coarse diamond burr here to drill the frontal beak. And just like how we do in ear surgery, first we start with a little lateral drilling, and only then do we proceed to a medial drilling. Here, this could be from anterior to posterior. So once we drill anteriorly, then gradually we progress to posterior drilling so that we expose and drill more and more bone for us to give a good vision inside the frontal sinus. Here, as of now, we are just using a 0-degree endoscope to be able to give us a clear look. And as surgery progresses, we'll probably shift to an angled endoscope, first 45 and then probably 70 degrees. Constant irrigation is very important while we drill because the drill and the bone gets overheated. Also, if there's inadequate irrigation, you see burns could also happen inside the nasal cavity on the mucosa or the septum, and thus leading to eventual scarring and synecdoche formation. So as we go more and more posteriorly, you see that we are constantly trying to drill slightly laterally, but more or less superiorly. Laterally, our limit is the skin, and as soon as we start seeing the skin, we need to stop. And as we drill more, again that last beak of the frontal beak, we could even nib it away slightly using a articulated punch. As you see here, our opening inside the frontal sinus is now becoming slightly bigger, though still not to the level of comfort for now. And one has to also keep in mind that whatever we create right now, it's going to it's going to get restricted or stenosed again by 40-50% eventually over 6 months. So then it has to be more than just allowing a suction to go inside. Now we have shifted to an angled endoscope, and as you see, our suction is just barely going inside. You see this now inside the frontal sinus with a lot of polypoidal tissue, though no fungus as such that has been seen. But as you see clearly that this opening is still quite restricted and is not good enough for either examination in the office or for the patient to do self-irrigation in the post-operative period. So we need to drill more bone. As of now, we are still using a conservative approach by not exposing the entire superior septum and the frontonasal process of the maxilla, because we do not want to do that much. It's not a case of malignancy or an inverted papilloma or a CSF leak. So while it comes to polyps, we can take a trial at slightly restricted drilling for an overall early recovery. So once those drills are used, and now we want to drill off just the beak itself and the edge of the beak. We use a 40-degree curved upwards sheathed burr to drill that uh, exact beak for us to create more space inside the frontal sinus ostium entry. Time and again, this is a mix and match of using both the heavy articulated punch as well as the drills to not using just one but both, to see that we are using all our instruments to the maximum to achieve the outcomes that we want. Now, as we have drilled the lip of the frontal beak now, the rest of it can be even extracted with a thick articulated punch like before. And now we see that gradually, slowly but steadily, we have achieved a larger opening of the frontal sinus. One can also see the anterior ethmoidal artery in the background on the skull base. And now with an angled 70-degree pointed upwards endoscope, you see the inside of the frontal sinus, which shows just some polyps and polypoidal tissue and not actual fungus. So while we drill more to not just create more space, but to create as much as possible a smooth bone all over for early epithelialization and mucosalization, because rugged bone or bone with a lot of projections can obviously impede healing and would be a site for new bone formation with the possibility of restenosis of the frontal sinus. More and more of this lip is being drilled with the upward angled coarse diamond burr, do at a slower speed to give us a slightly larger access inside this frontal sinus. But because one mustn't forget that though right now in the surgery, in this kind of field, one can irrigate clearly. But for the patient to irrigate the nose with high volume irrigation, there has to be a reasonable opening inside the frontal sinus for the irrigation fluid to go inside. So when most of it has been done, one can see the large wide enterostomy, the ethmoidectomy cavity where the suction is being used, the medial orbital wall, and this is an angled endoscope viewing upward the anterior artery and the frontal sinus opening post the drilling of the frontal beak, which seems to be adequate.